It's an exciting session. We heard quite a lot from Dr. Morgan and about the technology as well. So this next 20 minutes or so, if I can touch base on the challenges, it's a huge topic what I've been given, diabetes and infertility. It's slightly gross and it's got quite a lot of things that has to be taken into consideration. So what I've done is just about 2-3 case scenarios I've given, and then hopefully we'll learn from that. So this is what my talk is going to be, and one of the challenges, the PCOS, which I will talk very briefly. But this is the case of a male infertility. So a 32-year-old male, obese, and got married 4 years, and I think inability to conceive is the biggest challenge for this couple, and A1C is 8. How do you do it, and what do you do? Normally there is it is as I mentioned, as even the chairperson was mentioning, infertility is a big problem, and we know the diabetes itself is a huge challenge for our society, and the male reproductive function is definitely affected by that, and that has been proven with quite a lot of data that has been generated over time. And this is the mechanism of diabetes with male infertility. So if you go for the endocrine one, the hormonal challenges will be there. I'll touch base on the last case scenario, and then AG, advanced glycated end products, and then oxidative stress, and also diabetic neuropathy, which will be leading. I'll show a sketch will show how the diabetic neuropathy is affected. So 90% of the diabetics are affected with sexual dysfunction. The one thing we always discuss is the male sexual dysfunction, but the female sexual dysfunction is not being discussed anywhere, and a lot of data is not being generated in that area. And when the country is improving, probably that will come out as well, but we need to work on that. So it is as I said, there's quite a lot of data has been generated with the male fertility showing the sperm count is down, and then the DNA damage and the hormones are down. So the deficiency or the insulin or insulin insensitivity affect the endocrine pathway, and there are challenges with Sertoli cells, and then hormone sperm production is affected. So effect on sperm, the role of oxidative stress, it has got its own way of affecting it. I won't want to go into the detail, but you have to know that OS is affecting the sperm production. Now this is the thing that I was mentioning earlier. So diabetes leading to all this ROS and vascular endothelial damage, and also that will lead to diabetic neuropathy, and that will eventually, due to autonomic dysfunction and also direct involvement, the nerves will affect the fertility. So the altered nerve function will eventually lead to the damage for the male reproduction. Now this sperm, the diabetes and sexual hormones, I'll come to that in the last case study, but it will definitely get affected with gonadotrophins, and then the hypothalamus, even the secretion is affected. The sperm parameters in type 1 and type 2, so it is not sparing even the type 1 diabetics, so it is got the sperm shape and function is affected. So that is about the male one. As I said, it's a huge topic, but I just given justice to show how the sperm and the hormonal and the RAS pathway and other things affecting the male fertility. And coming to the female one, which is a huge challenge, if you look at it, this is the 31-year-old with PCOS for 12 years, irregular periods, and TSH is 7.8, and androgen levels are quite high. So how do you do it? It's a typical LH high and androgen levels are high. So how do you deal with this case scenario? As you know, infertility risk factors are menstrual abnormalities, androgen excess, and autoimmunity, sexual dysfunction. You would have seen yourself a lot of ladies come in with the infertility challenge. We got timer here? Timer there somewhere. Oh, that, right, fine. So a lot of the ladies would have come with autoimmunity, so you can't find anything else for their fertility challenges except the TPO antibodies, or something will be strongly positive. So and then obviously the sexual dysfunction as a whole will lead to infertility. So this is the hypothalamo-pituitary gonadal axis. This from the hypothalamus to pituitary, and then it goes to the theca cells and granulosa cell and the androgen. So if the wrong signal goes into ovaries, then the androgen will be produced more than the estrogen and progesterone. So this brings us to show that the type 2 is associated with all this, and then association of modern management and sexual dysfunction in diabetes. All these are the 3 parameters that as a gross I want to touch base on. So if you look at the metabolic syndrome and PCOS, it's going to be a bit theory, but I think this is the thing that mentions the insulin resistance will lead to quite a lot of challenges with free fatty acid, also reducing the insulin sensitivity, and that will lead to quite a lot of problems that leads to fertility. Now, depending on the diagnostic criteria, there is in India it's a huge challenge, but a lot of ladies are unreported for PCOS, and even if you consider how many people are reporting, it is the huge challenge for our community. So patient with PCOS associated, and then the thin PCOS are not addressed at all, but there are the weight, insulin resistance and dyslipidemia are the main 3 important factors. So hypertension, and the metabolic one is also very important, because even the girls who are in IT field and people are not working, sedentary lifestyle, they're getting into big problems because of that. At the early age, you seeing 26-year-old or 27-year-old male coming with heart attack, but similar to that, when you look at the woman, they will have 26 or 27, they'll have PCOS, and then the metabolic challenges already started developing. So that means that the diabetes and the obesity and also leading to metabolic syndrome related dyslipidemia, all causing problems. So by inducing excess androgen with adenocorticotrophic ACTH on the ovaries and adrenal gland respectively, and then the androgen excess further worsen the insulin resistance. So if you look at the relationship between insulin resistance and hyperandrogenism, it's a clear link that will cause the androgen excess. If you look at the metabolic disturbances, that will also lead to androgen like DHEA and other things. So androgens derangement will lead in metabolic syndrome, and then the androgen levels are quite high like testosterone. So that will lead to adiposity and insulin resistance. But if you look at it, there are multiple pathways and multiple relationships are there. So I won't go into the details, but obesity is another challenge that will lead to infertility. So you get a straightforward obese woman coming to your clinic with infertility. This is the 35-year-old married for 7 years, inability to conceive, and postprandially the blood sugar is high. How do you deal with it? As I said, the obesity, it's got a complex relationship. I'll show in the next case scenario, but the outcome of the pregnant women who, or the girls who are getting pregnant with obesity is very, very difficult in managing in terms of maternal side, also the fetal side. So increased BMI affect the fertility in multiple ways, and obese women have got a prevalence of amenorrhea and infertility even without any other explanation. That is because of you see typical PCOS women with LH high and SHBG low levels, sex hormone binding globulin, but again the same mechanism what I mentioned in the metabolic syndrome applies here. So what happens is the adiponectin, the fat hormones, which is being discussed more in endocrine world with modern generation. If you look at our ancestors and our parent generation, the fat levels may not be that high, but with the modern generation, the fat level is extremely high, and the fat cell has got a lot of hormones coming out. One is the leptin, adiponectin. So it causes adiponectin is a very good hormone that will help not having the atherogenesis and complex metabolic conditions. So If you look at the ghrelin, which is going to be there, anti-ghrelin, anti-serum, and quite a lot of GLP and GIP, like gut hormones in the next 10 years or so, even for diabetes treatment, you're going to see that area is the area that is going to be more developing or already in the research around pipeline for the areas where it is all the gut hormone related. So GLP, GIP, ghrelin, and a few other cholecystokinin, quite a lot of other gut hormones have been used as a therapy for type 2 diabetes. So women with PCOS have concentration of ghrelin, that weight matched control, and then androstenedione levels also getting affected. This published in JCM a long time ago. So obesity, I showed you how it affects the insulin resistance and also the metabolic things, but when it comes to pubertal and ovulatory dysfunction, you might have seen your neighborhood or somebody in your family or your friend circle that juvenile diabetes obesity is associated with early age at menarche, and also they will have multiple challenges once the menarche is attained in terms of irregularity and not having periods for a long time. So androgen status track from childhood to adulthood and is directly relating to the fertility. So obesity, PCOS and infertility, as I mentioned already when I spoke about PCOS and stuff, it will lead to all this, and eventually the infertility happens in a woman. They sit in a fertility clinics which are all flourishing in India now, with all the fertility centers all over the place, which you might not have seen about 10-15 years ago. Now you can see board of infertility centers all over the place. So instead it should be, my view, there should be more of obesity treating centers by properly trained doctors, and that is not happening, but it's more of infertility centers, and then the PCOS women and all the women go to gynec and get the things addressed that way. But obese women have insulin resistance, as I mentioned earlier, lower SHBG levels and pulse frequency of LH and attenuated LH pulse amplitude is there. So IVF success rate, I won't go into the detail, but there is big problem when you get a PCOS, and it is not an easy job. So that takes me to the last case scenario. So I showed you about a male infertility case and a female infertility case, and also about an obese woman getting pregnant. So this is a typical type 2 diabetic which you see in the clinic, and A1C is not controlled, diabetic dyslipidemia is there, and the patient is an antidepressant with SSRI, and BMI is there quite high. So patient is on quite a few drugs including Lantus, but is compliant. Before completing the pharmacotherapy, he is hesitantly asking about something about the bedroom, which just means that they are trying to talk about the sexual dysfunction, but further questioning in that area showed that erectile dysfunction ED is there, and pharmacotherapy workup is there, and what is the treatment that you normally give, and whether just explaining and giving a PDE5 inhibitor will be the straightforward answer, or whether there is any, what is the etiology that you could describe in this case scenario. So it is a complex mechanism. Hypogonadism is another thing that happens. So a concept of hypogonadotrophic hypogonadism happens in type 2 diabetics with obesity. What happens is the leptin level, it talks to hypothalamus, and the pulse secretion of the LH-FSH can be affected, and therefore the production of androgen is decreased. It is a complex mechanism. With the development of erectile dysfunction, these are all the things that is very, very important. You have to get a history from, and clinical implication. It has got a huge clinical implications in terms of even the psychological well-being. I showed you that case scenario with antidepressant on board, so it has got a huge impact on psychologically, that it might affect the clinical treatment or even the therapy of the patient. So ED will lead to cardiovascular disease, and this has been well proven. So if you got somebody with ED, that means that you have to screen them for cardiovascular disease. Anyway, you have to do it before giving PDE5 inhibitors, A lot of patients with PDE5 inhibitors, if they are on nitrates and other things, should not give that. So in this cohort of men, ED was associated with CVD. ED is part of the problem, but the point is the hypog is also prevalent in type 2. So how the evidence shows that the Dindesta, including 103 males, and it shows almost 33% of the males have free testosterone levels or less. So the percentage of hypogonadal man in type 2, it happens, it's published in JCM. And this is the trial from New York actually. It shows that hypog is common in type 2, and Kapoor is the guy who's done a lot of work along with the Dindesta in this area. And there is another guy when I worked in Lancashire, but the data is from Yorkshire actually. But the Kapoor one showed 75% of the people had got low testosterone, and this is the trial I was mentioning, trial from Yorkshire. Showing again the levels of testosterone is less in type 2 diabetic, and the men over the years it comes down. This is the JCM one and published in ADA. So hyperglycemia or age to blame when you get a hypogonadism, but it's clearly showed that directly the type 2 diabetes is the one of the factor that can affect especially when they got more fat. So obesity and metabolic syndrome, I'll skip that because I've spoken earlier about that, but the insulin resistance also will contribute because of that. Then the hypothalamic response, neurons that is affected in the mice model can kisspeptin and other things place. These are all the peptides that's been discussed in endocrine world a lot. So this is the cartoon that I want you to take home if you want to. So that shows that insulin resistance and hypogonadism, this is a complex link that happens with the GnRH release affected, and therefore LHFS is affected, and then that will lead to hypogonadism. And the leptin also plays a role. When the leptin level, I mentioned about the fat cells in the leptin level comes down, and then you get a GnRH release. The leptin level goes up, therefore the GnRH release is affected. So when you think about diabetes causing hypogonadism, what happens when the hypogonadal man, when you get a hypogonadism, a lot of people might have got experience in treating Kalman's syndrome, which is not very uncommon actually, and even the Klinefelter's one where the hypogonadism is there. You see these patients, HH and even IHH, idiopathic hypogonadotrophic hypogonadism cases, they'll have a low testosterone level. This is published data from 2010, and that concluded that these people who got hypogonadotrophic hypogonadism already will go into insulin resistance, and they'll get into type 2 diabetes. So hope you understand, insulin resistance will lead to hypogonadism, hypogonadism will lead to insulin resistance. So it is a complex mechanism, but it will lead to atherogenesis, and this is the evidence I'm showing, and CRP level also goes up, indicating hypog will lead to cardiovascular disease. And sexual dysfunction is also one of the things. So I would say with this thing, it is very common, and you need to consider that even before treating with PDE5 inhibitors. So almost end of my talk, so it's only one more minute. So I summarize that that infertility is very common in diabetics, and I've shown you a case of female with infertility where the main factors are all PCOS and obesity, and I've also showed you a male how the sperm and the quality of the sperm and the hormones are getting affected, and Ross pathway and other things. And then the third case scenario I showed you is obesity, but that will lead to infertility, and also the fourth one where the concept of type 2 diabetics leading to hypogonadotrophic hypogonadism, therefore the fertility is affected. Thank you very much for the wonderful opportunity, but lifestyle is going to be the key, and I'm happy to take any questions.